So you're standing in the ED, or maybe you're rounding on the stroke unit, and you're staring at a clinical picture that is, well, it's deceptively simple. You have a patient, maybe 65 years old. They've had a spell. Maybe their hand went numb for an hour, or they've got a very mild facial droop that's already, resolving.
Right. The CT is negative for hemorrhage. The diagnosis feels pretty secure. It's a minor ischemic stroke or a high-risk TIA.
It's the bread and butter of vascular neurology.
It is.
Yeah.
But it's also the moment where a clinician's instinct can actually lead them straight into a trap.
Right, because the gut reaction, the one we're all trained to have, is preservation mode. You see a threat, you want to neutralize it, you want to lock those platelets down so tight that nothing can move.
Absolutely. If one antiplatelet is good,
Aspirin plus clopidogrel must be better.
the more is better fallacy. I mean, it is incredibly pervasive. And to be fair, the fear is justified. The risk of a recurrent stroke in those first few days it's high. We are terrified of that patient coming back in a week with a massive hemiplegia because we didn't do enough.
So that really sets the stage for today's deep dive. We're looking at the delicate balance of dual antiplatelet therapy, or DAPT, specifically for that patient we just described, the minor stroke, the high-risk TIA.
Yeah.
We know the guidelines have shifted over the last decade, largely off the back of some massive trials like CHANCE and POINT. But looking through the protocols, there's a lot of nuance that gets lost in just the standing orders.
There is. And if you miss that nuance, specifically about the timing and the duration, you aren't preventing strokes anymore. You're just causing hemorrhages.
Okay, so let's start with the headline data, because I think we need to justify why we even take the risk of adding a second agent. We're talking about aspirin plus clopidogrel. When you look at those big trials, what is the actual magnitude of benefit here? Are we talking about like a 1% difference?
No, it's much more significant than that.
Yeah.
When you pool the data from these trials using DAP in this specific population, it reduces the relative risk of a recurrent ischemic stroke by about 25 to 30%.
25 to 30.
Compared to aspirin alone, yes. In the world of secondary prevention, where we usually fight for single percentage points, a 30% reduction is huge.
That is massive. That's the difference between a patient going home and a patient going to a nursing home.
Exactly. The signal is undeniable. The combination works.
Yeah.
I mean, it shuts down platelet aggregation through two different pathways, QX1 with aspirin, PDY12 with clopidogrel. It's a very potent shield.
But, and this is where we have to pump the brakes, that shield comes with a cost. I was looking at the safety outcomes in the POINT trial, and the bleeding risk wasn't trivial.
It wasn't. You're right. In a POINT trial, the risk of major hemorrhage was significantly higher in the DAPT group. And this brings us right to the central tension of this therapy. You are trading a reduction in clotting for an increase in bleeding.
And the art of medicine here is knowing exactly where those two curves cross.
It is. And according to the current consensus, that crossing point is day 21.
Day 21, that's the magic number.
That's the number.
I have to play devil's advocate here, because this is where I think a lot of clinicians struggle. If I have a patient who is doing well in DAPT at day 20, no clots, no side effects, it feels incredibly counterintuitive to strip away half their protection on day 22.
It feels wrong, I agree.
If it worked for 3 weeks, why wouldn't it keep working for 3 months?
You have to look at the physiology of the plaque and the timing of the risk. The risk of recurrence it's all front-loaded. It is highest immediately after the event. That first 24 to 48 hours is the real danger zone. That risk curve drops off steeply over the first few weeks.
So the fire's burning hottest right at the beginning.
Correct. You have an unstable ruptured plaque. It's raw, it's thrombogenic, you need the heavy artillery, the dual therapy to prevent platelets from just piling up on that raw surface. But by about 3 weeks, the body's done its job. Endothelialization has occurred, the plaque is stabilized, it's sort of healed over, so to speak.
Okay, so the benefit curve flattens out because the risk of a new clot has just dropped naturally.
Exactly. But the bleeding risk curve, that does not flatten out. That's cumulative. Every single day you keep a patient on DAPT, you are rolling the dice on a GI bleed or an intracranial hemorrhage. So after day 21, the benefit of preventing another stroke is basically zero, but the risk of causing a bleed just keeps on climbing.
So you're not protecting them anymore. You're just exposing them to harm.
You're running up a debt with absolutely no return on investment. And that's why the guidelines are so strict. Day 22, stop the clopidogrel. Continue aspirin monotherapy.
Let's talk about the start time, because that seems just as critical as the stop time. The protocols usually say initiation within 24 hours, maybe up to 48.
It has to be early.
Yeah.
Again, think of that risk curve. If you wait 3 or 4 days to start DAPT, you've already missed the window where the recurrent stroke was most likely to happen anyway.
I see the scenario sometimes. A patient comes in on a Monday. They say, "Doc, my arm went numb on Thursday, but I ignored it. It's better now." So they're 96 hours out.
Right.
Do you load them?
Generally, no. If they're more than 72 hours out from symptom onset, the ship has pretty much sailed. The benefit of aggressive platelet inhibition has diminished because that peak instability period is over. But if you hit them with DAPT now, you're giving them all the bleeding risk with almost none of the stroke prevention benefit.
That's a tough sell in the chart, though. Patient presents with stroke, physician prescribes less aggressive therapy. It feels like you're doing nothing.
It's not doing nothing. It's practicing evidence-based medicine. You put them on aspirin monotherapy, you manage their risk factors, but you don't expose them to DAPT because the math just doesn't work in their favor anymore.
Let's pivot to the WHO. We've been throwing around terms like minor stroke and high-risk TIA. These aren't just, vague descriptors. They have hard numbers attached to them in the trials.
They do, and this is where patient selection can fail in the real world. When the chance and point trials said minor stroke, they meant an NIHSS, a National Institutes of Health stroke scale of 3 or less.
3 is very low.
It is very low. We're talking about minimal deficits, maybe some sensory loss, a little dysarthria, mild drift. If a patient comes in with an NIHSS of, say, 5 or 8 significant weakness, aphasia, they are excluded.
Why? Why exclude the moderate strokes? Wouldn't they need protection even more?
It comes down to the brain tissue itself. In a moderate or large stroke, you have a significant volume of infarcted tissue dead neurons. That tissue is friable. The blood-brain barrier is broken down.
Okay.
If you flood that system with potent antiplatelets, you're just begging for a hemorrhagic transformation.
You're turning a dry stroke into a wet one?
Precisely. You cause bleeding directly into the injury. So DPT is strictly for the walking wounded. Small strokes, NIHSS 3 or less.
And for TIAs, how do we define high risk?
We use the ABCD2 score. It looks at age, blood pressure, clinical features, duration, and diabetes. A score of 4 or higher is the cutoff.
Got it.
Low-risk TIAs, someone whose hand was numb for 5 minutes and has no other risk factors, probably don't need DAPT. Aspirin alone is fine.
I want to touch on a specific exclusion that I think it's missed, because we get tunnel vision on the ischemic part of the diagnosis. We see a white spot on the MRI, we think clot, we think antiplatelet. What if that clot came from the heart? What if they have atrial fibrillation?
Then you absolutely do not use this protocol. This is a crucial distinction. The mechanism of a cardioembolic stroke, a clot forming in the left atrial appendage due to stasis, is completely different from an atherosclerotic clot forming on a plaque.
Antiplatelets don't work on the heart clots.
Not well enough. Cardioembolic strokes need anticoagulation. Warfarin, or the DOACs like apixaban or rivaroxaban. If you put an AFib patient on DAPT, you are treating the wrong disease mechanism. You aren't protecting them effectively from the next embolus, but you are definitely increasing their bleeding risk.
So this protocol is strictly for large artery atherosclerosis?
Yes. The patient with the carotid stenosis, the intracranial plaque, it is a specific tool for a specific job. It is not a pan-ischemic protocol.
I want to get into the safety check a bit more. We've identified the right patient, NIHSS of 2, carotid plaque. They arrived within 12 hours. We're ready to write the order. Is there anything that should make us stop? What are the red flags?
The biggest one is blood pressure. If you have a patient with uncontrolled hypertension, let's say they're running 190 over 100 and you can't get it down, you have to be very, very careful with DAPT.
Right. High pressure plus thin blood.
Equals hemorrhage, yeah. In the guidelines, we generally look at 180, 110 as a danger zone for thrombolytics. And while DAPT isn't TPA, the principle holds. You need to control the pressure.
And what else?
Other factors are pretty intuitive. A history of previous intracranial hemorrhage is a hard stop. Severe renal or hepatic failure can also complicate things because it alters how these drugs are metabolized. And of course, age.
Age? Is there a magic cliff at age 80?
No, it's a continuous variable, right?
Yeah.
But the older the patient, the more fragile the vasculature and the higher the risk of GI bleeding. So in the very elderly, you might think twice, or you might be even more vigilant about that 21-day stop date.
Let's talk about the logistics of that stop date, because in a hospital system, vigilance is often the first casualty of a shift change or a discharge summary.
This is the failure point. I see it all the time. The patient is started on DAPT in the hospital. It's appropriate. But then they're discharged. The discharge summary lists their medications. It says clopidogrel, 75 milligram daily. It does not say for 18 more days.
And the primary care doc sees it 2 weeks later, assumes it's a chronic med like the statin, and just refills it.
And suddenly the patient's on DAPT for 6 months. They come back with a massive lower GI bleed. That's an iatrogenic injury. It was preventable.
So how do we fix that? Because we can't rely on the patient to remember day 21.
You have to operationalize it. When I write the discharge orders, I don't write take for 21 days. I write stop clopidogrel on February 24th.
Yeah.
I put the actual calendar date in the instructions.
Ah, that's smart.
And I tell the patient, this is like an antibiotic course. You finish the course and you stop.
Viewing it as a course rather than a maintenance med is a great mental shift.
It has to be. It's a short-term intervention. It's like a bridge. Once you cross the bridge, you don't keep driving on it. You get off.
So just to sum up, if we were to boil this all down to a checklist for the next shift.
Okay, number 1, confirm the diagnosis. Minor stroke, so NIHSS less than or equal to 3, or high-risk TIA, which is an ABCD2 score of 4 or higher.
Got it.
Number 2, confirm the etiology. Large artery atherosclerosis only. No AFib.
No AFib. Critical.
Number 3, check the clock. You want to start within 24 hours ideally, but definitely within 72. After that, it's too late. Number 4, check the pressure. Make sure their BP is controlled. And number 5, the most important one, set the stop date. Day 21, hard stop.
And communicate that stop date to everyone who will listen.
The patient, the spouse, the nurse, and the PCP. Put it in flashing lights.
It's just so interesting. In medicine, we're trained to be aggressive, to intervene, to add medications. It feels productive, right? But this conversation really highlights that the decision to stop a medication is just as clinical and just as critical as the decision to start it.
It challenges the inertia of prescribing. It's psychologically harder to take something away. You feel like you're removing a safety net. But the data tells us that that safety net turns into a trap after 3 weeks.
We spend years learning dosages for initiation. We probably spent about 5 minutes in med school learning about deprescribing.
And that is where the harm happens, in the gaps where we forget to stop.
It really makes you wonder how many other forever medications on our patients' charts, PPIs, benzos, whatever, started out as a short-term bridge that no one ever bothered to burn.
That is a disturbing thought, but probably a very accurate one. We're great at starting fires to fight the enemy, but we aren't so great at putting them out when the battle is won.
Well, on that slightly terrifying note, we will leave it there. Check your patient's med lists, look for that stop date, and trust the data over your gut.
Absolutely. Thanks for the discussion.